Imagine you're sitting right across from a terrified patient. You're looking them in the eye, and you have to tell them that as their severed nerve heals, as their body actually regenerates and recovers, their hand is going to look significantly more deformed.
Yeah, it's a tough conversation.
Right. You have to prepare them for the reality that the visual clawing of their fingers will drastically worsen precisely because the nerve is finally working again.
Exactly. It's totally counterintuitive.
That dynamic, that terrifying clinical paradox, is exactly where we are heading today as we unlock the deepest intricacies of the human upper limb. So, welcome to the series finale of our upper limb pathology deep dive.
The big one.
Yeah, the culmination of everything we've been building toward. Today, we are specifically tailoring our discussion for those of you preparing for the FRCS in trauma and orthopedics. And look, we know exactly where you are right now.
Oh, absolutely. You are definitely not sitting at a mahogany desk with a, beautifully color-coded textbook.
No way. You are likely gripping a steering wheel, staring down a long commute, or maybe you're in the hospital kitchen aggressively scrubbing a coffee mug before an on-call shift. You're distracted. You can't take notes.
Which is exactly why the architecture of this deep dive is built entirely around audio retention. I mean, you just keep your eyes on the road, keep your hands in the sink.
We'll do the heavy lifting.
Right. We are going to build the surgical spaces, the intermuscular septums, and the fascial planes in your mind using nothing but spoken biomechanics.
And because we know your attention has to occasionally jump to a merging truck or a pager going off, we have a strict, unbreakable rule for this session.
A very strict rule.
Whenever we introduce a new nerve, a new compression site, or a key discriminator, we are going to state it twice.
Yes, we will repeat the structure 2 times in a row immediately upon introduction.
So when you're sitting in the exam hall staring down a vignette, you are going to hear those exact repetitions echoing in your head.
That's the goal.
So let's set the overarching framework for today's mission. I mean, the peripheral nervous system in the arm can feel like an untamable jungle of Latin terms.
Oh, it's a nightmare for trainees.
But there's a specific lens through which you can view every single multiple choice question they throw at you. And the framework is this. Every nerve has a signature. Every nerve has a signature.
I love that. Think of a nerve not just as a static electrical cable, but as a distinct biological identity. And it has 3 components. First, a specific muscle or group of muscles it powers. Second, a specific patch of skin it provides sensation for. And third, a specific undeniable hand posture it produces when it fails.
Right, so if you map the signatures for the median, radial, and ulnar nerves, you basically hold the cipher.
You do. But, the FRCS doesn't just test basic signatures. The examiners exploit a very specific twist.
They always do.
Yeah, and that twist is the level. The exact same nerve will produce a completely different clinical picture if it is compressed proximal at the elbow versus distal at the wrist.
Okay, the level.
Right. The exam writers know that candidates often memorize a simple formula like ulnar nerve equals claw hand. But if you don't understand the dynamic biomechanical changes between a high lesion and a low lesion, you will fall for their distractors.
I see candidates get trapped by that constantly. They memorize the what without understanding the why.
Exactly.
Well, we're going to eliminate that blind spot today by tracing the evolutionary and mechanical compromises of the human arm, the stuff that makes it uniquely vulnerable to these exact compressions.
Let's do it.
We'll start with the median nerve, looking at it high up near the elbow, and trace it down. Then the radial nerve, followed by the ulnar nerve. And finally, we'll dissect the clinical nuances of differentiating a peripheral nerve compression from a cervical root lesion.
Perfect.
Let's step into the forearm, the median nerve.
Okay, so as the median nerve travels distally past the elbow joint and enters the forearm, it gives off a highly specific deep branch. This is the anterior interosseous nerve. The anterior interosseous nerve.
Commonly known as the AI.
Exactly, the AIN. Now, the most critical discriminator for the AHAT, the defining trait you absolutely must anchor to, is its composition. It is a pure motor branch. It is a pure motor branch.
Okay, meaning it carries 0 sensory fibers, it doesn't receive input, it only dictates output.
Correct. So when this nerve becomes compressed, which is often by fibrous bands or maybe an aberrant Ganser's muscle or just trauma, it results in Kilo-Nevin syndrome.
Right.
And to understand this pathology, we have to look at the 3 specific muscular targets this pure motor nerve supplies as it runs down the interosseous membrane.
Okay, what are they?
First, it powers the flexor pollicis longus, or FPL.
Right.
The flexor pollicis longus. Second, it powers the pronator quadratus. the pronator
And
quadratus.
then,
And third, it powers the flexor digitorum profundus, specifically the radial half that supplies the index and middle fingers. The flexor digitorum profundus to the index and middle fingers.
I want to pause on the biomechanics there just because listing muscles can get a bit abstract. If I'm examining a patient and I suspect Kilo-Nevin syndrome, I'm looking for the failure of those specific muscles.
Right.
The FPL pulls the distal phalanx of the thumb into flexion. The FTP pulls the distal phalanx of the index finger into flexion. If those cables are cut, neurologically speaking, what does that actually look like sitting in front of me in the clinic?
The signature is the lost OK sign. The lost OK sign.
Right, okay.
If you ask a healthy person to make an OK gesture, they bring the very tip of their thumb to touch the very tip of their index finger, and that forms a perfect round circle.
Yeah.
But achieving that perfect circle requires aggressive flexion of the distal interphalangeal joints. You absolutely need the FPL firing to curl the thumb tip and the index FDP firing to curl the index tip.
So in an AIN palsy.
Those specific terminal flexors are totally offline. So when the patient attempts the OK sign, they literally cannot flex those distal joints.
Wow.
Yeah, instead of a round circle, the distal phalanges remain extended, and the patient ends up just smashing the flat volar pads of their fingers together.
So the thumb and index finger form a flattened triangle.
Exactly. They pinch flat.
The flat pinch is undeniable once you actually see it in practice. But, the FRCS will try to muddy the waters in the clinical vignette.
Oh, they love to.
They'll describe a patient with a flat OK sign, a weak pinch grip, but then they'll throw in a line about the patient experiencing radiating tingling in their index finger. If I read that sensory symptom, my internal alarms need to go off.
They absolutely must. Because the AIN is pure motor, there is absolutely no sensory loss. I will repeat that for the audio constraint. There is absolutely no sensory loss.
Okay, so pure motor.
Yes. If a patient presents with a flat OK sign, but they also complain of numbness, paresthesia, or tingling in the median distribution, you must immediately reject the diagnosis of an isolated AIN palsy.
Because the AIN does not innervate skin.
Exactly. The entire signature for AIN is a weak, flat pinch, the lost OK sign, and zero numbness. If there are sensory deficits, you have to look further proximal. You have to look at the main trunk.
Which brings us nicely to the main trunk of the median nerve around the elbow, which gives us pronator syndrome.
Yes.
If the main trunk is compressed, we aren't just dealing with a motor branch anymore. This is a mixed nerve, so we're going to see a completely different clinical landscape.
We are. Pronator syndrome involves the compression of that main median trunk. And because it carries both motor and sensory fibers before the AIN even branches off, the patient will present with an aching pain in the proximal volar forearm.
Like a heavy, fatigued feeling.
Right. And crucially, they will have numbness or tingling in the median distribution of the hand. So that's the thumb, index, middle, and the radial half of the ring finger.
Okay, and what's the physical exam maneuver they'll test us on?
A major clinical clue is that these symptoms worsen with resisted pronation.
So if I grip their hand, instruct them to pronate their forearm inward, and I physically resist them.
That muscular contraction compresses the nerve and reproduces the paresthesia.
Got it. But the exam won't just ask for the clinical presentation. They demand precise anatomical geography.
Of course they do.
So if I'm making an incision to decompress pronator syndrome, there are 4 sequential choke points I have to evaluate from proximal to distal. Let's map those out.
You really need to visualize the nerve descending the arm here. The first and most proximal site of compression is the ligament of Struthers.
Okay.
Moving distally across the elbow joint, the second site is the lacertus fibrosus. The lacertus fibrosus, which is the thick fascial expansion, also known as the bicipital aponeurosis.
Right, the lacertus fibrosus.
The third site is right between the two heads of the pronator teres muscle. Specifically where the nerve dives under the humeral head and over the ulnar head.
Okay, and the fourth?
And the fourth, most distal site in this cluster, is the fibrous arch of the flexor digitorum superficialis. The arch of the flexor digitorum superficialis, or FDS.
This is exactly where we have to flag one of the most notorious name clashes in the entire orthopedic syllabus.
Oh, yes. It's brutal.
You mentioned the ligament of Struthers as the first compression site for the median nerve, but there is a deeply confusing counterpart that the exam writers love to use as bait.
It's a devastating trap if you're moving too fast through the multiple choice options. The ligament of Struthers is a median nerve structure. Phylogenetically, it's a vestigial remnant. It runs from an anomalous bony supracondylar spur on the distal humerus down to the medial epicondyle, and the median nerve and often the brachial artery pass underneath it.
Right. But we have to contrast that with the other one.
Yes. You must contrast that with the arcade of Struthers. The arcade of Struthers is an ulnar nerve structure. Yes. It's a thin fascial band located higher up the arm, about 8 centimeters proximal to the medial epicondyle, where the ulnar nerve passes from the anterior compartment to the posterior compartment.
The nomenclature is just brutal. The examiners gives you a median nerve vignette, they ask for the compression site, and arcade of Struthers is sitting right there at option B.
Just waiting for you to click it.
We need to burn this into the listener's memory. We're going to recite this discriminator twice. Ligament of Struthers, median. Arcade of Struthers, ulnar. Let's lock it in again. Ligament of Struthers, median. Arcade of Struthers, ulnar.
If you anchor that distinction, you have safely navigated one of the most common pitfalls on the paper.
So as we wrap up this proximal median nerve anatomy, let's crystallize the key takeaways for the candidate who's, on the move.
If you only remember one thing from this segment, the AIN is pure motor, resulting in a flat OK sign with zero sensory loss. Pronator syndrome involves the main trunk, adding sensory symptoms that worsen with resisted pronation. And critically, the ligament of Struthers is a median nerve structure, while the arcade of Struthers is ulnar.
Perfect. We have conquered the forearm. Now we trace the median nerve distally, approaching the wrist, where it enters a rigid anatomical bottleneck.
The famous one.
Yeah, we were talking about carpal tunnel syndrome, CTS.
Every candidate thinks they know carpal tunnel because, well, it's the bread and butter of daily practice. But the FRCS tests it at a microscopic level of precision.
So let's start with the architecture of the tunnel itself.
Okay. The floor and walls are formed by the carpal bones, creating a deep sulcus. But the roof, the structure that makes this a true unyielding tunnel, is the transverse carpal ligament. The transverse carpal ligament. Older texts often call it the flexor retinaculum.
Right.
It's a dense, thick, fibrous band stretching from the scaphoid, tuberosity, and trapezium on the radial side over to the pisiform and hook of Hammett on the ulnar side.
Unyielding is really the operative word there. It's like an overcrowded subway car where the doors just won't stretch.
Exactly.
If the volume inside the car increases, the weakest occupant gets crushed, and the median nerve is always that weak occupant. So what exactly is packed into this rigid space alongside the nerve? We need the exact formula.
The exam demands, the content systematically. There are exactly 10 structures passing through the carpal tunnel. 10 structures, 9 of them are tendons, and 1 is the median nerve.
Break down the tendons for us.
There are 4 tendons of the flexor digitorum superficialis, 4 tendons of the flexor digitorum profundus, and 1 tendon of the flexor pollicis longus. So the formula is 4 superficialis, 4 profundus, 1 FPL, plus the median nerve.
I'm going to repeat that formula. Inside the carpal tunnel, you have exactly 10 structures. 4 superficialis tendons, 4 profundus tendons, 1 flexor pollicis longus tendon, and the median nerve.
That on.
So if we know what is inside the tunnel, the pathology of CTS is simply an equation of increased volume inside a fixed space.
Exactly. In most idiopathic cases, the tenon synovium lining those 9 flexor tendons undergoes hypertrophy. It swells, the volume goes up, and the median nerve is compressed against the transverse carpal ligament.
Simple physics.
Right. Now, the exam will frequently test the secondary systemic causes of this swelling. You need to instantly recognize the classic list: pregnancy, hypothyroidism, rheumatoid arthritis, diabetes, acromegaly, and amyloidosis.
But from an orthopedic trauma perspective, we must look at localized structural causes that physically invade the tunnel.
Yes, and this is where we encounter a brilliant orthopedic trauma trap.
Oh, lay it on us.
So the vignette describes a patient who falls on an outstretched hand. They present to the emergency department with acute wrist pain, profound median nerve paresthesia, and rapidly progressing carpal tunnel syndrome. The question asks which specific carpal bone pathology is causing the acute nerve compression.
Okay, so what is the reflex answer that gets candidates in trouble?
The reflex incorrect answer is a scaphoid fracture. The scaphoid is the most commonly fractured carpal bone, so candidates naturally assume it causes the most common nerve compression.
Right, it feels logical.
But biomechanically, a scaphoid fracture does not cause classic acute carpal tunnel syndrome. Its anatomical position doesn't directly impinge the nerve space in that manner.
So what's the real answer?
The definitive structural cause you must identify is a volarly dislocating lunate. A volarly dislocating lunate.
Let's visualize that mechanism. The lunate sits right in the proximal row, effectively forming the floor of the tunnel.
Correct. In a severe paralunate injury, the lunate is the final bone to fail. When it completely dissociates, the remaining ligaments act as a hinge, and the lunate physically rotates and spills out of the radiocarpal joint.
Just pops out.
Exactly. It translates volarly directly into the carpal tunnel space. It acts as a massive, hard, space-occupying lesion. It crushes the median nerve against the transverse carpal ligament, demanding an emergent surgical release and reduction.
That is a phenomenal visual. Scaphoid fracture does not cause acute CTS. A volarly dislocating lunate does. Now, let's dissect the median nerve right as it exits the distal edge of that transverse carpal ligament. There are two specific branches that act as critical clinical markers. Let's look at the motor side first.
Right at the distal margin of the transverse carpal ligament, the median nerve gives off a crucial motor branch that hooks back radially. This is the recurrent motor branch.
Okay.
This specific fascicle is the power supply for the thenar eminence, that fleshy muscular mound at the base of the thumb. It innervates the abductor pollicis brevis, the opponens pollicis, and the superficial head of the flexor pollicis brevis.
And when things go wrong?
When the median nerve is suffering severe chronic compression inside the tunnel, this recurrent motor branch loses axonal flow. Clinically, you see profound thenar wasting. The base of the thumb looks totally hollowed out and flattened.
If I see a patient with a hollowed-out thenar eminence, I know they have advanced long-standing disease. But here is the paradox that trips up early trainees.
This is a classic one.
That patient with severe CTS and a hollowed-out thenar eminence will complain of agonizing numbness in their thumb, index, and middle fingers. But if I take a pin and test the skin directly over that wasted thenar eminence, the skin at the base of the thumb, their sensation is perfectly normal.
It's wild, Ray.
How is that mechanically possible? If the entire median nerve is being suffocated inside the tunnel, why does that one isolated patch of skin retain perfect sensation?
This is one of the most heavily tested anatomical bypasses in the upper limb. The sensation to that specific patch of the thenar skin is not carried through the carpal tunnel. It is supplied by the palmar cutaneous branch of the median nerve. The palmar cutaneous branch.
Okay, the palmar cutaneous branch.
Right. The architectural genius here is that this branch sprouts off the main median nerve trunk approximately 5 centimeters proximal to the wrist crease. It branches off early, before the nerve ever reaches the choke point. And instead of diving deep into the carpal tunnel, it runs superficial. It travels superficially over the top of the transverse carpal ligament.
It takes the overpass while the main highway goes through the tunnel.
Exactly. It completely avoids the compression zone. So while the main nerve is being crushed inside the tunnel, causing the numb fingertips and the wasted muscle, the palmar cutaneous branch is riding high, safe from the pressure, delivering flawless sensory input from the base of the thumb.
And this isn't just an anatomical curiosity, right? It's a vital diagnostic discriminator.
Absolutely.
Let's apply it clinically. A patient comes in with numbness in their index and middle fingers, AND numbness over the thenar eminence skin.
If the thenar skin is numb, the palmar cutaneous branch is dead. And since we know it branches proximal to the wrist, the pathology cannot be confined to the carpal tunnel.
Right.
The compression has to be higher up the arm, proximal to where that branch splits off. It instantly redirects your diagnostic focus away from the wrist and up toward the forearm, strongly suggesting a proximal lesion like pronator syndrome.
That is how you use anatomy as a clinical scalpel. Let's synthesize the median nerve at the wrist for the listeners.
If you only remember one thing from this segment, the carpal tunnel holds exactly 9 flexor tendons and the median nerve. An acute CTS in trauma is caused by a volarly dislocating lunate, not a scaphoid fracture. And the palmar cutaneous branch bypasses the tunnel by running superficial to the retinaculum, which is why the minor skin sensation is uniquely spared in carpal tunnel syndrome.
Excellent. We've exhausted the volar aspect of the arm. Now we flip the limb over and dive into the extensor mechanics. We are tackling the radial nerve.
My favorite.
Specifically, its deep motor branch, the radial tunnel, and a very deceptive sensory syndrome. Let's trace the radial nerve as it crosses the elbow.
As the radial nerve descends past the radiocapitellar joint, it splits. The deep motor branch dives into the posterior compartment of the forearm by piercing through the 2 heads of the supinator muscle.
Okay.
Once it emerges on the distal side of the supinator, it assumes a new identity. It becomes the posterior interosseous nerve. The posterior interosseous nerve, commonly referred to as the pins end.
The pin end.
Yes. Just like the AIN we discussed earlier, the pin end is purely motor. It supplies the extensor muscles that lift the fingers and the thumb.
So if the pen is compressed, the muscles that extend the digits fail. The patient presents with a finger drop.
Right.
But this is where the biomechanical nuance is critical. A lot of trainees incorrectly assume that if the nerve powering the extensors is dead, the entire wrist should flop down into a profound wrist drop. Why does a pin palsy cause a finger drop, but absolutely not a true wrist drop?
This is a beautiful demonstration of anatomical timing. To extend the wrist powerfully, you rely heavily on the extensor carpi radialis longus, the ECRL.
Okay, the ECRL.
Here is the absolute discriminator. The nerve fascicles that supply the ECRL branch off from the main radial nerve proximal to the point where it dives into the supinator and becomes the pin. The power supply to the wrist extensor splits off early.
So the ECRL gets its electrical feed before the nerve enters the danger zone.
Exactly. In a classic pin palsy, the nerve is being crushed within or just before the supinator muscle. The downstream signals to the finger extensors are blocked. The fingers drop. But the ECRL, having received its innervation higher up, is completely unbothered.
It just keeps firing.
Right. It continues to pull the wrist into extension. However, because the other wrist extensors, like the extensor carpi ulnaris, are innervated by the PN and are offline, the ECRL is pulling unopposed on the radial side.
So what does that look like?
When the patient extends their wrist, it doesn't extend straight back. It deviates radially.
Right.
And crucially, to reinforce the signature, because the PI is purely motor, there is absolutely no sensory loss.
So the visual signature is a patient who can extend their wrist, albeit with the radial pull, but their fingers remain dropped, unable to straighten at the knuckles, and they feel normal sensation everywhere.
Yes.
If we have a pin palsy, where exactly is the nerve being strangled? We need the precise sites within the radial tunnel.
The radial tunnel is a potential space spanning roughly 5 centimeters, and there are 5 distinct anatomical structures that can act as guillotines on the nerve. You must know the absolute most common site above all others.
Okay, what is it?
The most common site of pin compression is the arcade of Frohse. The arcade of Frohse. This is a rigid, fibrous arch that forms the proximal edge of the superficial head of the supinator muscle.
Arcade of Frohse.
Right. Every time a human repetitively supinates the forearm, like a carpenter driving a screwdriver or a mechanic turning a wrench, that fibrous arcade of Frohse tightens like a noose across the pin. Let me repeat the dominant site. The arcade of Frohse.
For the sake of the FRCS multiple choice options, what are the other 4 potential compression sites in that tunnel?
Moving sequentially from proximal to distal, the first site involves fibrous fascial bands lying anterior to the radiocapitellar joint. The second site is the leash of Henry. The leash of Henry, which is a fan of recurrent radial blood vessels that dynamically cross over the nerve. The third site is the sharp, fibrous medial edge of the extensor carpi radialis brevis, or ECRB.
Okay, that's 3.
The fourth site is the arcade of Frohse, which we just highlighted. And the fifth and final site is the distal fibrous border of the supinator muscle as the nerve finally exits the tunnel.
We've established that a pin palsy spares wrist extension. So mechanically, what dictates a true wrist drop, where the entire hand hangs completely flaccid, unable to extend at all?
A profound true wrist drop requires a high radial nerve lesion. The injury must occur far proximal to the elbow, typically along the humerus.
Like Saturday night palsy.
Exactly. This is the classic Saturday night palsy where prolonged compression against the humeral shaft crushes the main radial trunk. Or it presents in a mid-shaft humeral fracture where the bone spikes lacerate or stretch the nerve as it wraps through the spiral groove.
The lesion is so high that it knocks out the main power grid before any auxiliary lines can branch off.
Precisely. It kills the signal before the ECRL branch can escape. The result is a total loss of wrist extension, complete loss of finger extension, and paralysis of the brachioradialis muscle.
And the sensory side.
Furthermore, because you have severed the main mixed trunk, you lose the sensory fibers before they can distribute. A high radial lesion will result in profound sensory loss, classically localized over the dorsum of the first web space, the skin between the back of the thumb and the index finger.
The contrast is undeniable. High radial lesion gives you a total wrist drop plus numbness in the first web space. PN palsy gives you an isolated finger drop, a radially deviating wrist, and 0 numbness.
Spot on.
Now, before we close the radial chapter, we have to navigate our second massive name clash trap. This one revolves around a purely sensory entrapment on the radial border of the hand. Wartenberg syndrome.
Yes, Wartenberg syndrome, also known by its archaic descriptor, choralgia paresthetica. Wartenberg syndrome is the entrapment of the superficial sensory branch of the radial nerve, the superficial sensory branch of the radial nerve. This compression occurs much further distally in the forearm, exactly where this purely sensory branch emerges from the fascia, between the brachioradialis and the ECRL tendons, about 9 centimeters proximal to the radial styloid.
Because it is a superficial sensory branch, motor function is entirely irrelevant here. There's no weakness, no wrist drop, no finger drop.
None at all. It is a purely sensory pathology. The patient presents with burning pain, numbness, and tingling over the dorsiradial aspect of the hand and the back of the thumb.
Like from a tight watch.
Exactly. It is classically provoked by tight wristwatches or handcuffs, and it beautifully mimics the tendon pain of Dick Ravane's tenosynovitis. But the examiner's trap doesn't lie in confusing it with Dick Ravane's. The track is confusing Wartenberg syndrome with Wartenberg's sign.
We have to draw a heavy, unmissable line between those two terms. Wartenberg syndrome versus Wartenberg's sign.
It is a non-negotiable distinction for the FRCS. Wartenberg syndrome is the radial sensory nerve entrapment we just described, pain on the back of the thumb. But Wartenberg's sign is a completely different clinical entity. What is it? It is a motor finding indicating an ulnar nerve pathology characterized by the little finger getting stuck in a constantly abducted posture. It has absolutely zero relationship to the radial nerve.
So why the same name?
Dr. Robert Wartenberg was a prolific neurologist who described both, leaving us with a treacherous homonym. Let's lock it in. Wartenberg syndrome is radial sensory. Wartenberg's sign is ulnar motor. Do not let them bait you.
Brilliant. Bring the radial nerve segment to a close for us.
If you only remember one thing here, a pion palsy results in a finger drop with NO, true wrist drop, and NO sensory loss, most commonly compressed at the arcade of Frohse. A true wrist drop dictates a high radial nerve lesion, and Wartenberg syndrome is a radial sensory entrapment, entirely distinct from the ulnar motor sign.
We are halfway through the anatomy of the upper limb. It is time to pull over for our first pit stop. If you are washing dishes, keep scrubbing, but listen closely. We are going to consolidate the architecture we've built. This is mid-episode recap 1, a rapid-fire synthesis of the median and radial nerves.
Let's go.
Starting with the median nerve. We detailed the AIN, the anterior interosseous nerve. It is pure motor. Its signature is the flat OK sign because the FPL and index FTP fail, and there is zero sensory loss.
Right.
Moving proximal, pronator syndrome involves the main trunk, causing aching pain and median numbness that worsens with resisted pronation. The 4 compression sites are the ligament of Struthers, the certus fibrosus, between the heads of pronator teres and the arch of FTS, our critical discriminator. Ligament of Struthers is median arcade of Struthers is ulnar.
Crucial distinction.
At the wrist, carpal tunnel syndrome. The tunnel is a rigid box holding exactly 10 structures, 4 superficialis, 4 profundus, 1 FPL, and 1 nerve. If a trauma vignette describes acute CTS, look for a volarly dislocating lunate, not a scaphoid fracture.
Exactly.
And the reason the skin at the base of the thumb remains perfectly sensitive is because the palmar cutaneous branch bypasses the tunnel entirely, ridding superficial to the retinaculum. Next, the radial nerve. The deep motor branch is the PN. It causes a finger drop, but the wrist still extends because the ECRL muscle receives its nerve supply proximal to the compression. There is no numbness. The most common site the PN gets crushed is the arcade of Frohse.
Arcade of Frohse, yeah.
Contrast that with a high radial lesion, like a humeral shaft fracture, which severs the main trunk, resulting in a total wrist drop and in sensory loss in the first web space.
Exactly.
Finally, Wartenberg syndrome is a purely sensory entrapment of the radial nerve near the wrist. This is entirely separate from the ulnar Wartenberg sign.
That is a dense, high-yield summary. If you have those principles anchored, you are ready to face the most complex, anatomically layered, and counterintuitive nerve of the upper limb.
There we go.
We are moving into the ulnar nerve. We will map the cubital tunnel, Guyon's canal, and deconstruct the infamous ulnar paradox.
Let's start proximal. The ulnar nerve at the elbow. Everyone knows the sensation of striking their funny bone, that violent electric shock shooting down into the ring and little fingers. That is acute trauma to the ulnar nerve and its bony groove. But chronic, insidious compression in this region is cubital tunnel syndrome.
Cubital tunnel syndrome is the second most common compression neuropathy in the human body. And just like the radial tunnel, the exam requires you to know the exact anatomical choke points. There are 5 classic compression sites for the ulnar nerve around the elbow, and we must sequence them from proximal to distal.
Walk us through them.
The highest, most proximal site is the arcade of Struthers. The arcade of Struthers. As we emphasized during the median nerve discussion, this is the ulnar fascial structure, not to be confused with the median ligament.
Right.
Moving distally, the second site is the medial intermuscular septum. The medial intermuscular septum as the nerve pierces it to enter the posterior compartment.
Okay.
The third site is the rigid bony constraint behind the elbow, the medial epicondyle groove. The medial epicondyle groove.
That's 3.
The fourth site is the actual roof of the cubital tunnel proper, formed by Osborn's ligament. Osborn's ligament, a fascial band bridging the humeral and ulnar heads of the flexor carpi ulnaris muscle.
And the final one.
And the fifth, most distal site in this region is the deep flexor pronator aponeurosis. The deep flexor pronator aponeurosis as the nerve dives deeply into the forearm.
Let's hear that whole list again.
I'll run that sequence one more time. Arcade of Struthers, medial intermuscular septum, medial epicondyle groove, Osborn's ligament, and the deep flexor pronator aponeurosis.
So the ulnar nerve navigates that gauntlet at the elbow, travels safely down the ulnar aspect of the forearm, and arrives at the wrist. And just as the median nerve has to survive the carpal tunnel, the ulnar nerve faces its own discal bottleneck.
Yes, it enters Guyon's canal. Guyon's canal. This is the distal compression site for the ulnar nerve. It is a distinct fibro-osseous tunnel situated on the ulnar border of the wrist, bordered by the pisiform medially and the hook of the hamate laterally.
The etiology of compression in Guyon's canal is quite different from the carpal tunnel. We don't typically see the systemic synovial swelling of pregnancy or hypothyroidism here.
No, Guyon's canal compressions are predominantly mechanical and traumatic. The classic FRCS scenarios involve a fracture of the hook of the hamate, which directly compromises the lateral wall of the canal. You also see ganglion cysts arising from the underlying tracheotohamate joint invading the space.
But there's a highly tested vascular cause too, right?
Yes. The most highly tested etiology relates to the ulnar artery, which runs intimately alongside the nerve within the canal. Repetitive blunt trauma to the hypothalamic eminence can cause ulnar artery thrombosis or a false aneurysm, which then acts as a space-occupying lesion, compressing the nerve.
Like in specific professions or hobbies.
Exactly. You see this in avid cyclists who support their weight on their handlebars, causing cyclist palsy, or in tradesmen who use the heel of their hand as a mallet, resulting in hammer users' palsy.
We have established the high compression zone at the elbow and the low compression zone at the wrist. Now, we must confront the monster. This is arguably the most counterintuitive biomechanical concept in upper limb anatomy, the ulnar paradox.
It really is a monster for trainees.
I'm going to push you to break this down mechanically. Logically, a more proximal, higher injury to a nerve should produce a more devastating, severe clinical deformity. I mean, if you sever a major power line at the source, the whole city goes dark. So mechanically, how does a higher ulnar nerve injury result in a less severe physical deformity in the hand?
The ulnar paradox is a brilliant demonstration of dynamic imbalance. It confuses everyone until they visualize the opposing muscle groups acting on the fingers like puppet strings.
Okay, set the baseline for us.
Let's establish the baseline. The signature posture of a failed ulnar nerve is the claw hand. Specifically, the metacarpophalangeal joints hyperextend and the interphalangeal joints of the ring and little fingers flex inward into a claw. To understand the paradox, you have to understand the two opposing forces controlling those joints.
What's the first force?
The first force comes from the heavy lifters up in the forearm, the flexor digitorum profundus, or FDP. The ulnar innervated half of the FDP acts like a thick, powerful industrial cable, pulling the distal tips of the ring and little fingers down into a tight fist. That is your heavy flexing force.
Okay, the FDP is the heavy cable. And the opposing force?
The opposing force comes from the delicate intrinsic muscles located entirely within the hand, the interosseous and the ulnar lumbricals. Their complex biomechanical role is to flex the knuckles and extend the interphalangeal joints, effectively balancing out and resisting that heavy curling pull from the FDP. They are your delicate balancing force.
So you have that massive FDP pulling the fingertips into a curl, and the intrinsic hand muscles acting as the brakes, trying to keep the fingers somewhat straight and balanced.
Exactly. Now let's analyze a low lesion, a compression strictly at the wrist, in Guyon's canal.
Okay, down at the wrist.
If the nerve is crushed at the wrist, the electrical signal to all those delicate intrinsic hand muscles is destroyed. The balancing brakes are completely gone. But because the lesion is at the wrist, the nerve supply to the massive FDP muscle up in the forearm is perfectly intact. The FDP was innervated much higher up.
Oh, I see.
So what happens mechanically? The heavy FDP cable is firing at 100% power, violently yanking the fingertips into flexion, and there are absolutely no intrinsic muscles alive to resist it.
Because the brakes are dead.
Exactly. The result is a profound, severe, tightly curled claw. A low lesion equals a massive claw.
That makes perfect mechanical sense. The forearm muscle is running wild without any intrinsic hand muscles to govern it. Let's move the injury proximal. What happens in a high GH lesion at the cubital tunnel?
If you compress the ulnar nerve high up at the elbow, you obliterate the nerve supply to the hand intrinsics, just like before. The brakes are dead.
Right.
But here is the critical biomechanical twist. Because the lesion is high up in the elbow, you also cut the nerve supply to that heavy FDP muscle in the forearm. The FDP is paralyzed.
Wow.
So now the delicate balancing muscles are dead, but the heavy cable pulling the fingers into a tight fist is also dead.
The dynamic pull is gone. If the FDP is paralyzed, it literally cannot yank the fingertips down.
Precisely. The fingertips simply sit there, relatively flaccid. You still observe a claw posture because the intrinsic balance is ruined and the radial innervated extensors are pulling the knuckles back. But without the FDP forcefully curling the tips, the clawing is noticeably milder.
Because there's nothing pulling them into that tight fist.
The mechanical truth is that a high lesion paralyzes the flexors too, so the fingers don't flex as much.
It's all about who is left pulling the strings. Let me deliver the mandated mnemonic. We will state this twice to anger it. The higher the lesion, the lower or less the deformity. The higher the lesion, the lower the deformity. A high elbow injury looks milder. A low wrist injury looks horrific. That is the ulnar paradox.
Once you map the vectors, the paradox resolves into pure logic. To wrap up this segment on the ulnar nerve topography, if you only remember one thing, remember that the cubital tunnel has 5 compression sites, including the arcade of Struthers. Guillen's canal is the distal choke point at the wrist. And the ulnar paradox dictates that a lower lesion claws more severely, while a higher lesion claws less severely because the FDP is paralyzed.
Now we have to translate that anatomy into the physical examination. When you are assessing a patient with a suspected ulnar neuropathy, the examiners will test your knowledge of specific eponymous signs. They will describe the physical maneuver in text and ask you what it signifies.
We must begin with the most famous ulnar nerve test in orthopedics. Froment sign. The clinical setup is elementary. You hand the patient a piece of paper and instruct them to pinch it tightly between their thumb and the radial side of their index finger, simulating a key pinch. You then attempt to pull the paper out of their grip.
I have to challenge this setup. We are evaluating the ulnar nerve. But during our median nerve segment, we established that the muscles flexing and opposing the thumb, the FPL, and the thunder group are powered by the median nerve. Why are we utilizing a thumb pinch to interrogate the ulnar nerve?
That is exactly the nuance that makes the test brilliant. It is true that the median nerve powers the FPL to flex the thumb tip, but the specific muscle required to strongly adduct the thumb to pull the thumb flat and powerfully against the index finger for a robust key pinch is the adductor pollicis. And the adductor pollicis is the only sanguine thumb muscle exclusively innervated by the ulnar nerve.
Ah, so the key pinch specifically isolates the adductor pollicis.
Correct. If the ulnar nerve is compromised, the adductor pollicis is weak or, frankly, paralyzed. The patient physically cannot maintain a strong, flat pinch on the paper.
So what do they do?
However, the patient's brain is still commanding the hand to hold onto that paper at all costs. So the central nervous system recruits a workaround. It fires up the median innervated FPL as a substitute.
It recruits the other nerve.
Right. But the FPL is designed to flex the interphalangeal joint, not to adduct the thumb flat. So as you pull the paper, you will observe the patient's thumb interphalangeal joint suddenly flex and hook down as they desperately try to grip it.
The median nerve is literally cheating on behalf of the failed ulnar nerve?
Exactly. It is a profound compensatory mechanism. That sudden hyperflexion of the thumb interphalangeal joint during a pinch is a positive Froment sign. It visually confirms that the ulnar innervated adductor is dead and the median innervated FPL is compensating.
That is a beautiful biomechanical workaround. What is the next sign? We discussed the nomenclature earlier.
Yes, Wartenberg sign. To reiterate, this is the ulnar motor sign, not the radial sensory syndrome. You instruct the patient to rest their hand flat on a desk with their fingers fully extended. You will observe that their little finger is stuck in an abducted posture. It drifts away from the ring finger, and the patient cannot actively pull it back into alignment.
What forces it to drift away?
It is another unopposed vector. The muscle responsible for adducting the little finger, pulling it inward, is the third palmar interosseous muscle, which relies entirely on the ulnar nerve. If the ulnar nerve fails, that palmar interosseous is paralyzed.
So the brake is off again?
Exactly. Meanwhile, the extensor digiti minimi muscle on the dorsum of the hand, which is innervated by the radial nerve, remains completely healthy. Due to its anatomical insertion, it possesses a slight ulnarward abducting force vector.
So the radial extensor just pulls it out.
Yes. With the palmar interosseous dead and unable to provide resistance, the radial extensor unopposedly drags the little finger out into abduction. That uncorrectable drift is Wartenberg's sign.
And what about the specific nomenclature for the clawing itself?
The exam may use the formal French eponyms. Duchenne's sign refers specifically to the classic ulnar claw posture hyperextension at the metacarpophalangeal joints and flexion at the interphalangeal joints of the ring and little fingers, resulting from the paralysis of the ulnar lumbricals. And Peter's test-it sign is the physical inability to actively cross the fingers or spread them apart, which demonstrates the profound paralysis of the dorsal and palmar interosseous muscles.
So we have an arsenal of signs proving the ulnar nerve is failing. But we still face the ultimate surgical dilemma. Is the nerve trapped proximal at the elbow or distal at the wrist? We know the ulnar paradox gives us a visual clue, but clawing can be ambiguous in early stages. Is there a precise geographical anatomical test to definitively prove the level of the lesion?
There is, and it is perhaps the most elegant diagnostic tool in clinical anatomy. It relies entirely on a specific sensory fascicle called the dorsal cutaneous branch of the ulnar nerve. The dorsal cutaneous branch.
Okay, walk us through it.
You must visualize its exact anatomical course. As the ulnar nerve travels down the forearm, approximately 5 to 8 centimeters proximal to the wrist crease and Guyon's canal, it bifurcates. It sends off this dorsal cutaneous branch, which sweeps dorsally, wrapping around the ulnar border of the wrist to provide sensation to the skin on the dorsum of the ulnar hand and the back of the little finger.
It bifurcates early. That is the exact same architectural logic as the palmar cutaneous branch of the median nerve bypassing the carpal tunnel.
It is the exact same logic. Because the dorsal cutaneous branch splits off high in the distal forearm, it entirely bypasses Guyon's canal. So let's execute the clinical reasoning. A patient presents with a classic ulnar claw hand. You take a neurological pin and stimulate the dorsum of their little finger. If the patient reports normal, sharp sensation, what is your geographic conclusion?
Well, if they feel it, the dorsal branch is perfectly healthy, which dictates that the nerve compression must have occurred distal to where that branch split off. The lesion has to be trapped low down at the wrist, specifically within Guyon's canal.
Flawless logic. Now, what if you stimulate the dorsum of that little finger and the patient reports complete anesthesia? It is totally numb.
That means the dorsal cutaneous branch is dead. And since it branches off proximal to the wrist, the main nerve trunk must have been crushed somewhere above that bifurcation. The lesion has to be proximal, up at the elbow in the cubital tunnel.
Exactly. Assessing the sensation on the dorsum of the little finger instantly and definitively localizes the level of the lesion. Sensation spared equals distal compression at the wrist. Sensation lost equals proximal compression at the elbow.
That's incredibly clean.
And from an operative perspective, this nerve is a massive hazard. When you are performing an ulnar shortening osteotomy for ulnar impaction syndrome, you are making your cut in the distal third of the ulna. This dorsal cutaneous branch is sweeping directly across the subcutaneous border of the bone in that exact zone. It is the structure you are at highest risk of transecting if you don't respect the fascial planes.
That ties the physical exam directly to the surgical approach. Let's lock this segment down.
If you only remember one thing here. Froment's sign demonstrates the median innervated FPL compensating for a paralyzed ulnar innervated adductor pollicis during key pinch. And the dorsal cutaneous branch is spared in a wrist-level lesion, but lost in an elbow-level lesion, serving as the ultimate geographic localizer.
We are in the home stretch of the upper limb. It is time for our second and final mid-episode recap. If you're managing a distraction, refocus on the audio.
Listen up.
Ulnar nerve. High compression is cubital tunnel syndrome, and the 5 sites include the arcade of Struthers. Low compression is Guyon's canal at the wrist.
Right.
The ulnar paradox is entirely dictated by the heavy FDP muscle in the forearm. A high lesion paralyzes the FDP so it cannot pull, resulting in S-clawing. A low lesion leaves the FDP intact so it pulls violently, resulting in a massive claw. The higher the lesion, the lower the deformities. The signs. Froment's sign is the thumb interphalangeal joint hyperflexing. because the FPL is substituting for a weak adductor pollicis. Wartenberg's sign is the abducted little finger drifting outward. Duchenne's sign is the eponym for the claw posture itself.
All classic signs.
And to geographically locate the lesion, check the dorsum of the little finger. If feeling is spared, the lesion is low at the wrist. If it's numb, the lesion is high at the elbow because the dorsal cutaneous branch was knocked out before it could branch.
That brings us to our final segment. We need to address the ultimate diagnostic dilemma that separates the junior trainee from the FRCS consultant.
Oh, the roots.
Yes. Differentiating a peripheral nerve compression from a cervical root lesion in the neck. Because to the untrained eye, a distal nerve entrapment and a proximal radiculopathy can look identical in the hand.
This is a classic ward round scenario. A patient complains of numbness in their little finger and weakness in their grip. The junior doctor reflexively diagnoses cubital tunnel syndrome. But the consultant examines the patient and declares, no, this is a C8-T1 nerve root compression from a cervical disc herniation. How did the consultant differentiate a high ulnar neuropathy from a cervical root pathology, given they both manifest with deficits in the exact same territory of the hand?
The distinction relies on mapping the anatomical footprint. A peripheral nerve, like the ulnar nerve, possesses a very strict, localized territorial boundary. A spinal root, such as C8 or T1, contributes fibers to that peripheral nerve, but it also contributes fibers to other completely separate nerves. Therefore, a root lesion will exhibit a much wider multi-nerve footprint.
So what's the test?
The most elegant clinical discriminator to separate an ulnar nerve lesion from a C8-T1 root lesion is to evaluate the sensation on the medial forearm, the cutaneous territory on the inside of the forearm between the elbow and the wrist.
Why is the medial forearm the key?
Because the ulnar nerve does not supply the cutaneous sensation of the medial forearm. Let me reiterate that. The ulnar nerve does not supply the medial forearm.
Really?
Yep. That patch of skin is innervated by an entirely distinct nerve called the medial antebrachial cutaneous nerve. The medial antebrachial cutaneous nerve.
Okay.
This nerve does not travel with the ulnar nerve. It originates directly off the medial cord of the brachial plexus, high up in the axilla, and travels down the arm independently. However, the sensory fibers within the medial antebrachial cutaneous nerve originate from the exact same C8 and T1 nerve roots in the cervical spine.
Ah, I see the overlap.
Exactly. So if a patient suffers a compressed ulnar nerve at the cubital tunnel, their medial forearm will retain perfect, normal sensation because the medial antebrachial cutaneous nerve is structurally independent and safely bypassing the elbow compression.
Right.
But if the patient has a crushed C8 or T1 root in their neck, that single compressed root starves both the ulnar nerve and the medial antebrachial cutaneous nerve.
Because it's happening at the source.
Yes. The result, the little finger will be numb, and the medial forearm will be numb. If the medial forearm is numb, you are definitively not dealing with an isolated ulnar nerve entrapment at the elbow. You are dealing with a proximal cord, plexus, or cervical root pathology.
That is a master class in clinical localization. Check the medial forearm. Are there corroborating motor tests to confirm this root versus nerve distinction?
Yes, you look at the motor footprint. If you suspect a T1 root lesion, inspect the thenar eminence of the thumb. The T1 nerve root contributes heavy motor fibers to the median nerve, which ultimately powers those thenar muscles.
Okay.
An isolated ulnar nerve compression at the elbow will never result in wasting of the median innervated thenar muscles. But a T1 cervical root lesion will simultaneously cause the ulnar intrinsic muscles to atrophy and the median thenar muscles to atrophy. You observe a globally wasted hand.
The whole thing is wasted.
Exactly. So a numb medial forearm combined with the denar wasting definitively equals a proximal neck problem, not a distal elbow problem.
That logical framework applies across the entire plexus, doesn't it? What about the median nerve? How do you reliably differentiate carpal tunnel syndrome from a C6 cervical root compression?
You apply the exact same mapping logic. A C6 cervical root lesion will not restrict its sensory deficits to just the thumb and index finger. It compromises the entire C6 dermatome, which extends proximally all the way up the radial border of the forearm.
It's a much bigger area.
Right. Furthermore, a root lesion will disrupt spinal reflex arcs. A C6 compression will demonstrably diminish the biceps and brachioradialis tendon reflexes. Carpal tunnel syndrome is a purely distal peripheral entrapment. It will never affect reflexes at the elbow.
Plus the clinical history.
Definitely. CTS presents with classic historical markers. It is highly localized to the hand, often involves pure thenar motor weakness, and classically wakes the patient from sleep due to nocturnal fluid redistribution. A root pathology yields a broad myotomal and dermatomal deficit. A peripheral nerve yields a strictly governed local territory.
That is phenomenal clarity. Okay, we're going to conclude the factual content with a rapid review of two specific wrist and hand pathologies that the FRCS loves to test as standalone discrete facts. First, the biomechanics of wrist arthrodesis or wrist fusion. If you are performing a total wrist fusion for severe radiocarpal arthritis, you cannot simply fuse the joint at neutral 0 degrees. You have to establish a specific angle.
You must fuse the wrist in the position of maximum functional grip strength. To understand this, make a tight fist right now. You will immediately notice your wrist naturally cocks back into extension.
Yeah, it definitely does.
This occurs because slight extension maximizes the length-tension relationship of your flexor tendons, allowing them to generate maximum force. Therefore, when surgically fusing a wrist, the mandated target position is 10 to 20 degrees of dorsiflexion, which is slight extension.
Okay.
And you simultaneously position it with slight ulnar deviation. Let's encode that precise specification. 10 to 20 degrees of dorsiflexion with slight ulnar deviation. 10 to 20 degrees of dorsiflexion with slight ulnar deviation.
The power position. And our final topic, the late complications of a collis fracture. This is the classic distal radius fracture with dorsal angulation. The exam will present a list of late complications and ask, which of the following is not a recognized complication of a collis fracture?
You have to know the genuine complications to confidently identify the distractor. Genuine late complications of a collis fracture include acute median nerve compression. The fracture hematoma causes an acute carpal tunnel syndrome.
Makes sense.
Another highly tested complication is the delayed rupture of the extensor pollicis longus, or EPL tendon. The EPL tendon anatomically wraps around Lister's tubercle on the radius. As the fracture heals, the jagged bony callus creates friction, leading to attrition and delayed rupture of the tendon weeks later, causing the patient to suddenly lose thumb extension.
Ouch.
Malunion is also incredibly common, resulting in altered ulnar variants, as is profound joint stiffness. But the trap answer, the specific pathology they always insert as the false option, is a vascular necrosis of the lunate bone. A vascular necrosis of the lunate.
Which is clinically recognized as Kimbuk's disease.
Correct. Kinbuk's disease is its own distinct pathophysiological entity. It involves the vascular supply to the lunate failing, often correlated with repetitive microtrauma or negative ulnar variants, altering the load transmission through the radiocarpal joint.
So it's totally separate.
It is absolutely not a recognized direct complication of a traumatic collis distal radius fracture. So, EPL tendon rupture, yes. Median nerve neuropathy, yes. Lunate vascular necrosis, no.
Let's give them the final takeaway for this segment.
If you only remember one thing from this final section, a numb medial forearm dictates that the lesion is proximal to the ulnar nerve, pointing to a root or plexus pathology. And a functional wrist arthrodesis is positioned in slight extension and slight ulnar deviation.
We have survived the jungle. We have covered a massive volume of neuroanatomy, and now you're going to forge it in fire. This is our final lightning round.
Let's see what you've got.
I'm going to ask the question, and the expert is going to deliver the precise, unyielding answer. If you are listening, try to shout the answer before the expert does. Here we go. AIN palsiant. What is the signature visual sign, and is there any sensory loss?
Flat OK sign, and absolutely no sensory loss. It is a pure motor branch.
Ligament versus arcade of Struthers. Which is which?
Ligament of Struthers is median, arcade of Struthers is ulnar.
In a trauma setting, what carpal tunnel cause is the exam trap?
A scaphoid fracture is not a cause. A volarly dislocating lunate IS a cause.
Why is the NER skin sensation spared in carpal tunnel syndrome?
Because the palmar cutaneous branch runs superficial to the retinaculum, bypassing the tunnel completely.
Pin palsy versus a true wrist drop. What is the fundamental difference?
A pin palsy produces a finger drop with NO wrist drop and NO sensory loss. A true wrist drop dictates a high radial lesion with sensory loss.
What is the most common anatomical site of pin compression?
The arcade of Frohse.
Explain the mechanics of the ulnar paradox.
The higher the lesion, the less severe the clawing, because the heavy FDP muscle in the forearm is paralyzed and cannot flex the fingertips.
What does a positive Froment sign demonstrate?
It demonstrates the median innervated FPL compensating for a paralyzed ulnar innervated adductor pollicis during a key pinch.
If a patient presents with an ulnar claw, but also exhibits a numb medial forearm, where is the pathology located?
The pathology is proximal, accord, plexus, or T1 root issue, not an isolated ulnar nerve entrapment.
And finally, what is the optimal surgical position for a wrist arthrodesis?
10 to 20 degrees of dorsiflexion with slight ulnar deviation.
Incredible. We have traced 3 major nerves from the elbow to the fingertips. We have identified their distinct anatomical signatures, and we have proven that you must always question the level of the lesion, because the level changes the entire biomechanical reality.
It changes everything. Understanding this anatomy is not just an academic exercise to pass a multiple-choice paper, it is the foundation of surgical competence. When you understand the ulnar paradox, you aren't just memorizing a quirk, you are preparing yourself to guide a patient through the terrifying reality of nerve regeneration, where their hand will visually worsen before it truly heals. When you understand the dorsal cutaneous branch, you aren't just passing a test, you are actively avoiding transecting a nerve during an osteotomy. The anatomy is the map to safe surgery.
And with that, we conclude the series. 7 deep dives from the unstable shoulder all the way down to the clawed hand. If you have been listening through, you have walked the entire upper limb, joint by joint, nerve by nerve. Take a breath. Be proud of the hours you've put in on the commute or at the sink.
You've earned it.
If there were areas today that felt slightly out of grasp, don't stress. Just let this audio run again on your next drive. Trust the signatures. Good luck with the FRCS. You've got this. See you on the other side.